Well, ladies and gentlemen, welcome to Evergreen Talks. My name is Dr. Tim Powell. I'm the President and Medical Director at Evergreen Family Medicine. On my left is Dr. Shelley Britton. Dr. Shelley Britton is a specialist in internal medicine, and she has brought a grace and intelligence to our group that's been very welcome. So I'm proud to consider her my partner there at Evergreen. She's on our board. We're going to talk tonight about a very important topic, but I want to make sure folks understand this is the first of a number of town halls that Evergreen is intending to have. I hope it's helpful to you. It's important to us that we engage the community over things that are important to us. And although they will perhaps often be health related, that is disease related, such as diabetes, it'll also be a more broad discussion at times, maybe diet and lifestyle, health policy, insurance issues, access, mental health, chronic pain, addiction medicine, concerns that are important to our community, and we look forward to engaging the community. We call that Evergreen Talks instead of Evergreen Speaks because there's going to be an opportunity for question. That's what a talk is. It's not one way, but we're going to begin. Now, you guys have been given packets, lots of stuff in there. We'll go over those, but included in that are some question cards in your packet. And if you have a question, I hope you'll feel free to write that question down, and towards the end we'll collect those and we'll go for those and talk about that. I really do want to say again that I'm honored by you folks coming out tonight. It's Thursday night, the Pac-12 tournament's going on, lots of things to do, and you've exchanged that for what can be an uncomfortable discussion. As I talked about the hour before, as I thought about the story of the preacher, he really wanted to instill a sense of urgency into his congregation, get their attention, so he kind of bellowed out, everybody in this congregation is going to die. And well, you know, kind of comfortable and responding, and so it got the effect he wanted, so he repeated it. I said, everybody in this parish is going to pass away. And again, people were sort of squirming, except for one guy. One guy in the very front row had this big smile on his face, and the more he repeated his messages, this smile got bigger. And so he said, you know, what's up with you? Why are you so happy? And the guy said, hey, I'm just visiting, not from this congregation. That's not something we're able to say. We're not from this place when we talk about the realities of passing time. And so your attendance tonight is an acknowledgement that when it comes to these difficult end-of-life decisions, somebody will make the decision. The decision will be made, and your presence speaks to your desire that you control what you can, that you avoid a circumstance where guilt or pressure may be placed onto other people, and that can be unfair. So you're taking that on to yourself. And I tell you why I think that's important, because too often the decisions made by others really don't reflect what the person would have chose, because decisions made by others oftentimes are tinged with a desire to avoid guilt, desire to avoid maybe not doing enough, and I think they make sometimes very conservative and very careful decisions that may not be in line with what you would have chose for yourself. And the reason I say that is there was a large survey, and when asked where they would want to spend their last few months, 80% of Americans said they wanted to be at home with family and friends, free from the institutional grip of a hospital or a nursing home, and in relative comfort. One man said, you know, I want to die like my Uncle Bob, just in his sleep, not screaming like all those other guys in the bus he was driving. But But the truth is, only 24% of Americans older than 65, only 24% of Americans older than 65 die at home. 63% die in the hospital or nursing home. Oftentimes they're tethered to machines, oftentimes they're in pain. And you have to wonder why that is. And that concern is at the very center of why we're here tonight, because what I have seen so often is that in the name of caring, these decisions are oftentimes hijacked by medical technology. And the results they produce can be cruel. We pass over the line between prolonging life and prolonging death. And it all begins with the very best intentions. It's a seductive process, and it's a side effect, if you will, of the extraordinary progress we've made in medicine. We're creating expectations that aren't real, and mostly, please hear me now, we're allowing the assault of medical interventions that were never intended to be applied at the end of life. I want you to think about what I just said. Let me give you an example with just something most of you would be familiar with, is CPR. CPR, of course, is cardiopulmonary resuscitation, and it's wonderful. It was introduced in the 50s or 60s in its current form in American medicine. It was designed to help previously healthy patients. Patients that might be the victim of drowning, heart attacks, drug overdoses, electrocutions, and other reversible conditions. And in that context, it saved many, many lives. But now, unless one has very specifically prohibited its use, it's routinely applied even to the most sometimes elderly patients, patients with chronic diseases, patients in poor health, often with results that are appalling for those that have been a witness to that. There's a doctor by the name of Dr. Kuhler, it's spelled with a K, and he wrote an article in the New York Times, and it was called "The CPR We Don't See on TV." And I just want to read that with you because as I read that, I understand in a second what he was talking about. The first time I saw a patient who had received CPR, the experience wasn't what I expected. Sure, I thought she wouldn't look well. After all, her heart had just stopped. But I wasn't prepared for the scene before me. Frail woman, mid-80s, barely conscious, vomiting, broken ribs, bruised lung. Her stomach was bloated, her chest was bleeding. She looked more like a survivor of CPR than a cardiac arrest. And when she died a few days later, I couldn't help wondering if she really knew what she was getting herself into. I've had similar emotions as I've driven home or went home thinking about the last moment on earth of a patient I really cared about. Moments that were, instead of peaceful leaving this earth, were filled with strangers pounding on their chest, shoving tubes into the throat and applying electrical shocks, when often there was very little hope of gain. But how do you know? Isn't that the question? How do you know? We understand we don't want to be that lady, but life is precious. Life is precious, and none of us get old overnight. Disease doesn't come in a day. And a decision that's easy when you look at it at a distance and you look at it in theory becomes a little more real and a little more difficult as that day approaches reality. We don't want to give up too early. Everybody's decision is personal. It's personal to their age and their health. It's personal to their own experiences that they've seen with other family members or people they've loved. It's personal to their belief systems. But no matter how personal it is, those expectations and decisions should be guided by facts. And that's the purpose of tonight's discussion. Let me say this about CPR. The success of CPR in restoring life and the potential for a quality of life is dependent on many factors, but the most important factor is simply this: what was the health of the patient prior to CPR? Why did the heart stop beating in the first place? There was a study, and this was presented in a journal called CHEST. This is a professional journal for pulmonologists and medical intensivists, people that work in the ICU. And it was really kind of an incredible story, incredible by the number. It was over 10 years. In the age group, you can see everybody was 67 or over. And it was between 250,000 and 500,000 people that had CPR. And that's a large number. Those of you that understand clinical studies understand that the more folks you have in the study, the more accurate your conclusions can be. Not only was that a huge number, but it was over 10 years. And it was actually written in 2014, so they had a good 10-year gap. And their question was simply, how did these people do? How did these people do? And as I wait, not quite turning to the next slide, I'd like you to envision in your own mind what you think that outcome would be. What would you expect it to be? Kind of place in your mind of what that was. Now, I want you to understand they divided these 350,000 people into two groups, equal in both groups. One was a healthy group. I'm 67, so as healthy as somebody 67 can be. But the other group had chronic disease. And so if you're going to say chronic disease, you have to define that. And you can't define every type of chronic disease there is, but when the ones they use got most everybody. COPD, you'd think of that like lung disease, maybe emphysema, malignancy, cancer of any kind, cirrhosis, that's liver problems, severe congestive heart failure, chronic kidney disease, and diabetes. So half these people that had CPR had a chronic disease listed there, and half of them did not. And again, I'd like you to kind of think in your mind what you think the outcome was. Next slide. I don't know what you expect in terms of CPR and the outcome, but when they said how many of these people actually survived to discharge, in the healthy population, that number was 17%. Now, those are people that had an arrest in the hospital. I mean, where else might you have it that you could do better at? No, this is in the hospital. The people with chronic disease, and I mentioned what chronic disease was, it was between 11 and 16%, depending on the diagnosis of what the chronic disease was. And so that's a little sobering, but it's still helpful. That's 17% that would not have lived otherwise, and they survived to discharge. How long did they survive after discharge? And I want you to look at those numbers. The median survival for people with no chronic disease was a little over 2 years, 26 months. Now, what you need to realize is, for your own experience, you don't live on the average. You have either 0 or 100%, and so there are people in there that may have lived 10 years, and other people lived a week or two, after going home. But the average was over 2 years. Those with the chronic disease cases that I indicated there, it was less than 6 months survival after. You know what that says to me? It says to me that the prize too often that is won by those who survive is an opportunity to go through it again. I don't mean to be cruel with that, but in a certain population, that's the truth. And you know what? That's worth talking about. So the question I have for you is, have you had that conversation?
Have you had the conversation? Not the one about sex, not the one about drugs, not the one about money. We're talking about the really essential conversation.
So I figured it would be a really easy conversation. My parents were really open to it. They thought it was a good idea, and I could not get myself to start it.
It was really something that made me uneasy, and it was something that I was really uncomfortable with.
So I knew that I should have it, and somehow I think found every reason not to have it.
and I wasn't ready to think about what does it mean that my dad's going to pass away at some point, and how do we deal with that.
And I never thought that I would have to make decisions like this for my mom.
The conversation is a process. It's not a one-time thing. At least I don't see it as a one-time thing. I think it's nice to revisit periodically.
So instead of having the conversation with my family, I did end up having the conversation with several people, several of my friends from a similar cultural background.
So finally, we went for a hike and we were supposed to have a conversation at dinner. That didn't happen. And then we went home. We still hadn't had the conversation. And finally my dad said, I thought we were going to have a conversation. So that's how it started. And suddenly I realized in the moment I needed to become very, very, very quiet. And my mom needed to become very, very, very loud. And I started to just listen in a very, very present way to every single thing that she had to say. And then suddenly I started to know what questions to ask. And they weren't clinical questions. It was like, at what point, Mom, do you want me to step in and help make decisions for your life? And she said to me, well, at the point at which I can't sit down and pray with you kids. And that's really poignant. That's not making a decision about a ventilator. That's not making a do not resuscitate decision. That's something very, very simple. And all I could say to her is, yes, Mom, I will do that for you.
Because I think that the human thing is to feel like, I don't want to play God. I'm not in a position to play God and make a decision about someone's life or death.
My sister and I had very different views about what we should be doing. And in our conversations, it wasn't about what I wanted or what my sister wanted. It was about what my dad wanted and now what my mom will want for her care. What was important for my dad was that he be at home with his family. He did not want to be in the hospital while he was really ill. And it turned out that he wanted to die at home. And we were able to do that for him.
I think we really talked about the spirit of what is life to you and what does it mean. And I think my mom, the most powerful thing she said was, you just need to know to tell the care professionals who are taking care of me or him who we are when we're not in a hospital bed. And if they know that, I have no doubt that you'll be able to have a conversation with them about what is the right kind of treatment.
I wish I could have sort of looked my father in the eyes and had that conversation. But I think that what most of us end up doing is just the best we can under really, really difficult circumstances.
You know, I have a son, and then I'm going to have the other talk at some point in his life. And it's like, you're going to have these talks throughout your life that are just uncomfortable. But if everyone is aware that they have to have that talk and can talk about it, you know, it makes it easier.
I think it made us closer because we were able to talk about and emotionally deal with how we felt. I could tell my dad, I love you, and I don't want to talk about this, but we need to talk about it. And we got to respect each other for that.
And now, knowing how comfortable my mom is, and it only came from that conversation, we're much more comfortable that it's just another stage in life, and it will be just fine.
As we turn the lights back on.
Finally tonight, an inside look at complicated end-of-life decisions. Tonight's edition...
I'd like you folks, as you think of them, to turn in your question cards, and we'll be by to collect those in just a little bit. So at the end of our conversation, we can have some common questions that may have occurred to you. This is, again, Dr. Shelley Britton.
Thank you again for coming tonight. Thank you for sharing some time with us. I'd like to tell you a story about my late friend Ron. I've not used his real name, but his story is very real. He was my patient and my friend for the decade prior to his recent death. As I prepared for tonight and we sat down and talked about things in the office last week, I found myself really choking with emotion and just having to recount his story because he was someone that was important to me. He was my patient and my friend for the decade prior to his death, and he was one of the remaining members of what's been designated as the greatest generation. He was born to a working class family in New England. He enlisted in the Navy as a young man and proudly served our country in the South Pacific and World War II. He was one of the fortunate ones to be able to return home, to take a wife, and to return to live his version of the American dream. Life circumstances brought him to the West Coast when he was an adult, and the wife of his youth passed when he was in his 50s. He was fortunate to find another loving wife with whom he would spend the rest of his days. Having been self-employed as a barber for much of his life, he was very meticulous with his care. He shaved with a straight razor until the last days of his life. And his daughter removed it, concerned that he would end his life prematurely with the razor. He took very obvious pride in his home. It was a modest home, but very comfortable. Really, he was a good citizen by every measure. He loved his wife. He loved his country. He paid his bills. He was well known by his family for his generous spirit. I met him in my clinic when I moved to Roseburg, and I was really taken by his kind demeanor and the concern he had for his wife. And while he had his own health concerns, his primary concern was really for the well-being of his wife and for maintaining a safe home in which they could both live. As his own health had declined, it had become increasingly difficult for him to manage his yard and his home. His children were of older age and had their own health problems and really were not able to help him with some of the things that he needed. My husband and I visited with him in his home on many occasions, and we lent a helping hand with some of the things he couldn't do. Our teenage son went with us, and later when he was able to drive, he went by on many occasions to mow his yard or to help pick things up. Usually he would leave with a box of cookies or a $5 bill. I strictly forbade him from taking any significant amount of money because this was something that we just needed to do. I tell you all this about Ron, not to tell you about what my family did with him, but rather to let you know that he's someone that I knew well. I really liked him. I liked his wife. It was a real joy for us to see him because we don't have any family in the area, and both my husband and I grew up with older relatives, and we spent a lot of time with helping in their care. Ron always had a quick smile and a good story to tell us when we were there. But time doesn't stop for any of us, and it did not stop for him. As he passed age 90, he suffered a number of falls. His memory began to fail, and physically he was really a shadow of his former self. He realized this, and despite his fierce independence and his pride, he clearly understood that he was not going to win the battle he was facing. At an office visit sometime back, after he'd had yet another fall and another emergency department visit that ended with stitches in his head, I had a difficult conversation with my friend. And when we talked about the ravages of age on his life and the toll it was taking, I asked him what he wanted. I was concerned about how I could ensure his dignity when he could no longer make his own decisions. And I needed to know who would make those decisions for him. Ron was very clear in stating that he'd lived a good life. He understood his mortality, and we completed a POLST, which we'll talk about later. That is a physician orders of life-sustaining treatment for him to ensure that no medical providers would offer him any support beyond that which he designated. He did not want to be placed on a ventilator or to have CPR administered. He did not want to receive any tube feedings, but he did want other things that may help him to continue in his life. His concern, again, as we had this conversation, was for his wife, as his memory was still better than hers, and he was concerned about what she would do when he couldn't help her any longer. The next couple of years were quite difficult for him as his physical and mental health continued to deteriorate. At the end of his life, he required help with bathing, help with meal preparation, and even with making sure his medications were correct. Fortunately, he was able to get a lot of help in his home through the Veterans Administration. My last meeting with Ron was just a few weeks ago, and honestly, he looked the best I had seen him in the previous year. His daughter brought him in. He was in a wheelchair. He was clean. He was smiling. We had a really nice talk. And as we hugged goodbye, I was just thrilled to see him. Later that night, as I was looking over things from the day and looking to see who was in the hospital, I saw his name on the patient list. He'd actually gone to the emergency department the afternoon after I saw him, and that night had been admitted to the intensive care unit. His heart was failing, and my friend was dying. He didn't live until the next morning, despite the efforts that were made that night. And honestly, there was no procedure that could have saved his life or restored his health at that point. The next day, feeling really sad, I reviewed the nurse's notes regarding his final night in the hospital, and his wishes to avoid advanced procedures had been honored. I know our ICU nurses here, and they really provide amazing and very compassionate care to the folks who are here. But it troubled me to learn that in his final hours, he'd been there without any family. Because by design, his wife, who was not well, had to be taken home. As the night had gone on, he'd gotten progressively confused, and in an effort to prevent him from taking out the IV lines that were administering medications to try to give him some help, he had to be placed in hand restraints so that he wouldn't pull those out. And I read the notes and I thought of my respect for the man that I had come to know over the preceding years. I knew he was in good hands with the ICU nurses, but it truly bothered me that he'd been there with nobody that he knew that night. We'd had many conversations over time, and I still questioned myself, did I do everything that I could do as his friend and as his physician to ensure that he had both comfort and dignity in those last hours? Did I help him finish as well as he desired? When I think about people approaching the end of life, the things that come to mind for me and the things that my patients want to be sure of is that their wishes are respected and that they're treated with dignity. And as Dr. Tim has stated, death it's difficult to think about. It's even more difficult to discuss, even for us as physicians, but it's really something that we all have to face. Many of us have very strong feelings about what we do and don't want to have done when we can't make those decisions for ourselves. And our families want to make the right decisions. The families that I work with, they want to make the right decisions for the folks that I'm seeing. But they need some guidance from both the patients themselves as well as from medical providers as to what might be helpful. So what are we talking about when we talk about these terms such as CPR, ventilatory support, and tube feeding? CPR, as we've talked about, is cardiopulmonary resuscitation. And when we think about it, that's when chest compressions are administered. That's when supplemental efforts are made to help with breathing. And typically, if a person survives those efforts, that person is placed on a ventilator. When a person's on a ventilator, a plastic tube is inserted through their nose or their mouth. It's placed through their vocal cords and into their trachea, or where I grew up, we called it the windpipe. The tube is attached to a machine called a ventilator, which delivers oxygen. It delivers the oxygen rhythmically through the tube, it inflates the lungs, and then it pauses and the air can flow back out. This is generally what people refer to as life support. And there are times when ventilator support is needed for a temporary procedure or an illness to allow that person to recover. For instance, if someone has pneumonia and they're in generally good health, if they become very ill, sometimes they will require ventilatory support and they can recover from it. The person who's on the ventilator is heavily sedated to prevent anxiety about the fact that they have a tube stuck through their vocal cords and into their trachea or windpipe. Their hands are usually restrained to prevent them from pulling the tube out inadvertently. And while this tube is in place, folks can't talk because there is the tube through their vocal cords. And what do we mean by tube feeds? So when we have tube feeds, a flexible plastic tube is placed through the nose and it's guided through the esophagus and down to the stomach. Liquid nutrition is delivered through the tube. There are times when tube feeds are needed to help a person recover from a serious illness, but if long-term feeding is needed, then a surgical procedure is done and there is a puncture placed in the abdominal wall right into the stomach, and a plastic tube is put from the outside of the abdominal wall right into the stomach to deliver those tube feeds. These are the processes that are noted in both the PULSed and the Advanced Directives document. So the PULSed is the pink form that folks see and that many of you have seen before or have helped with family members in completing. PULSed is an acronym for Physician Orders for Life-Sustaining Treatment, and you do have a copy of that in your packet. The PULSed is a legal medical order. The order gives directions to emergency personnel and other medical providers regarding a person's desires about CPR and whether or not ventilatory support would be desired. Also, it offers guidance about other advanced medical support that may be offered in an intensive care unit. And then finally, it talks about whether or not there would be any circumstance in which a person would want to be fed through a feeding tube. This form is not for everyone. The PULSed is an appropriate form for the person who has frail health regardless of their age, or for an elderly person who would likely not survive or benefit from these advanced procedures. If a person wants to have full support to include all of these measures, a PULSed is really not needed because that's what we assume that everybody wants if we don't have that form. The Advanced Directive is a separate form. You also have that in your packet. And it's a document really for any adult to complete. That document makes the person or persons that a patient would desire to make medical decisions for them known to the medical providers. So if a person is not able to make medical decisions for themselves, those persons would be listed and they would help in making the decisions. It gives those advanced directives to the person who would be then called your healthcare proxy to make decisions for you about what you do and don't want to have done if you can't make decisions yourself. Decisions about CPR, ventilator support, and tube feeds. And so now Dr. Powell is going to talk a little more about these forms.
Thank you, Shelley. So the forms you have in your green notebook, and I wouldn't mind if you pull those out just to kind of look at them so we can talk about them together and you can see what I'm saying. I want you to understand that these are the tools by which you communicate what you want to other people, to physicians and to your family. They're tools to communicate. It's not the only way to communicate. You can still just talk to people and tell them what you want, and I really encourage you to do that, especially your family that may not know exactly how you feel. They may assume they know, but they don't. So there it is, that old bright pink form that all of you have, and all of you have seen probably at some time or another, probably maybe even attached to a refrigerator of somebody. And what it says, and the reason they put it on the refrigerator, is what Dr. Britton says, the default position, unless they see that, is they always resuscitate. That's just where our culture has come, that unless they have a specific order not to, the paramedics or anybody else that engages you during a time of your life when you need critical help is going to begin the CPR and the things we do to try to revive you. Let me say something about this, and Dr. Britton already did, so I'm really repeating. This form is not for everybody. It is for people that are fragile. It is people for people with chronic health issues that are very clear in their mind that they do not want to be resuscitated. So I call it a direct form, and there's no room for nuance. The first, number A, there's 3 questions you can answer, and only 3, but if number A, you say attempt resuscitation, honestly, you don't need to fill out the rest of it. Because it goes, you're going to get full treatment if we're going to attempt to resuscitate. Sometimes there's incongruencies here. A person will say, up here, do not attempt resuscitation. Down here, they'll say full treatment, and those are in direct contradictions to one another, and the doctor should ask you for that, or they'll say comfort measures only, and then attempt resuscitation, or do not accept in full treatment. Sometimes just don't go together. There will come a time in your life and in mine when that's the appropriate form. It may or may not be at this time, but there will be. My father passed away this last September. He was 101 years old. He was passing away of natural causes. How crazy would it be to try to revive him for a little bit more? My mother passed about 10 years ago. She had advanced Alzheimer's disease. And once again, I had no desire to try to bring Mom back to experience more of that, because at the very best, when they bring you back, they're going to bring you back to what you were before you had the process. I want you to understand some things about that. DNR, if you choose DNR, and again, there's only 2 choices here. If you choose do not resuscitate, then you should also choose between A and B. I mean, comfort measures or limited treatment, but you don't want full treatment. And honestly, as far as the 2 feedings, it probably doesn't matter what you put there, because that's going to be very individual, and a lot of times I tell people just put number 1 there, a defined treatment time, because if sometimes there's need for 2 feeding just for a few weeks to get by a situation with the esophagus or something where we can return swallowing or a stroke, and we do it for a little bit, and then in a month or 2 they're able to swallow again. And so you have to be cautious saying never any artificial nutrition by tube. Sometimes it can be very, very helpful. Although, if you have chosen do not resuscitate, it's very reasonable to also say, I don't want to do with that. I want you to understand something, and you heard it in Dr. Britton's comments. First of all, do not resuscitate doesn't mean no care. Do you hear that? We still provide all the care. We just stop when it comes to the point of resuscitation. It does not mean no care. There'll still need to be decisions. There'll be sometimes people will say, I want no care, but this does not address this. This simply says if it comes to a place where your heart stops, we are not going to shock it and push on your chest and put a tube down to try to get it going again. So DNR does not mean no care. The second is this: at Evergreen, we, with all of our people 65 and over, we do annual wellness visits every year. And what you filled out last year or 5 years ago may still be okay, and it may not. So we revisit that annually. For example, with Ron, perhaps he would have chosen not just only do not resuscitate, but comfort care only. And that would have prevented some of the things that disturbed Dr. Britton so much. There's a home in Calcutta, India, and it has an Indian name, but it's called Tender Heart. And I had a friend that visited that, and as he went in, they take the most destitute of people in there, and he told me of this scene of a young woman feeding, cradling an older man in her arms and using a dropper to feed, some of it going down his cheek. But what was so very, very compelling to him was how that man, he may have been a young man also, but his time was growing short. He was very emaciated, skin taut over his bones, and how he just stared and stared and stared, transfixed at the face of this person feeding him with not like an infant over his beloved mother. It may have been the first time he was held in that way since he was an infant. The Teresa method in India is bringing dignity to the dying. It is not, as in America, death with dignity, which is a euphemism for assisted suicide. But that's what Shelley was talking about, Dr. Britton was talking about with Ron, a desire to bring dignity to the dying, and that's what the post implies. So if, with the post, you're at a place where you're quite comfortable saying, for myself, I don't care what happens, as I would have said with my dad and my mom, we're not going to resuscitate this person, then DNR, or do not resuscitate, is appropriate, and probably comfort measures only is appropriate. And then you're through with that form. If you're not there, then put that form down. It doesn't belong to you yet. And pick up the other form. It's a magazine. It's called the Advance Directive. I want you to look at that because, folks, this is your friend. It is not to be feared. Every single one of you need to complete this. That magazine can intimidate you. It's a lot of stuff in there, and it doesn't have to. And I'm going to show you why. Now, too often, here's what I hear. Here comes Aunt Katie through the emergency department. She's had a large stroke and is in a coma. And I'm beginning to stabilize the patient, and here comes the niece from Kansas City. And I say, well, did Aunt Katie have an advance directive? Well, yes, I think she did. Well, where is it? Well, probably in our attorney's office. And what did it say? Well, the only one that knows that is Aunt Katie, and she's not talking. And so I'm going to go through this and show how we get around that. But I wanted to tell you that this does not have to be intimidating, it does not have to be feared. So I'm going to have you turn to the blue section, page 2. I want you to find the blue, you can see it on the corner tab there in page 2. And I want you to know, and it's on the phone here too, this is the only legal aspect, the only legal page in the whole magazine. It is the only legal page, and it's where you appoint 2 healthcare representatives. The rest of the magazine is about you, but it's not for you. Who it is for is those 2 people whose name you've put down there. So it's important to let them know what you want. It's important to maybe share a copy with that. But it's also important to know that this only comes into play. You're not giving away your friends, or you're not giving away your rights in any way. The only time this comes into play is if you cannot speak for yourself. If you're horribly demented, or if you're in a coma, if you can speak for yourself, we talk. You and I talk, and we decide what you would like to do. But when you cannot, that's when this comes into play. So if you fill out no other page on this entire thing, fill that one out, and that will be very, very helpful. Now I want you to skip over and join me on the blue, page 4. In the first forms, I heard somebody say, this looks a little different than what I had before, and it does. In the first form, this was a state committee that put this together, and they thought they had really done some heavy lifting with these 4 questions. It wasn't that helpful, because a question that really only has one answer isn't a question at all, it's a rhetorical question. So I'm going to read these to you. If I'm close to death and life supports would only postpone the moment of my death. If I'm unconscious, and it's unlikely I'm ever going to become conscious again. If I have a progressive illness, it's fatal. It's in an advanced stage, consistently, permanently. I can't communicate, I can't swallow food or water, I can't care for myself, I don't recognize my family or other people, I'm never going to get better. And then the next one, and this is kind of my favorite of rhetorical questions, if life supports would not help and would make me suffer permanent and severe pain. And then they ask if you want life supports. And what I'm saying to you is the two people whose name you put down there as representatives, they could probably figure that out without that help. But whereas the pink form is very black and white, this really fills in the nuance, because so much of life is nuance. It isn't a situation as desperate as these. A lot of my patients will tell me they don't fear dying, they just don't want to die halfway. Where they're really dependent on others for care, they're a shell of themselves and don't recognize what's going on. So I'm going to have us go to the next page. So I've showed you the kind of the main details here where you fill out a healthcare representative. But again, understanding the nuance that comes in so many circumstances, and they aren't in a place where it fits one of those extreme circumstances, but they're still not where they want to be. They created this, and now we've gone to the very front, and it's called the conversation starter. And I think they've done a great job with this. Because what they've done, next page, is they've produced a lot of vignettes or story problems up there that introduce a situation. Here's Sam, and here's Don and Don and Judy, and they introduce a circumstance. They begin to define terms that we use, like terminal condition, quality of life, advanced directive, and so forth. And then they have some discussion questions. Nothing to write down here, just things to think about, things to talk about. That's the conversation. That's the conversation. You know, what do you think about that? And sometimes, if you can begin that conversation will then drift into specific areas that are more pertinent to exactly where your circumstances are. Next slide. And so again, they begin to produce vignettes there where we might use food and water or CPR, but they describe all the terms, and every time they have a discussion question. Next slide. And they go on for breathing machines, and I will tell you that the living with dementia is a huge one, and if you haven't dealt with that in some way, you're unusual. And it's heartbreaking. It is just, there's nothing harder. And I'm not telling you how you should feel about that. I said everything is personal in dealing with that, but having gone through that with so many of my patients, having gone through that with my mom, I've told my wife and I've told my children, if I become severely demented, such as my mother did, I don't want you to do a thing to keep me alive. I don't want you to treat pneumonia. I don't want any treatment for anything. Now that may not be the right choice for you, but I know it is for me. So dementia is a big one. They talk about things like palliative care here, and is an interesting thing with palliative care and even hospice is that we find a lot of times people that have given up on, quote, active care and purely went to comfort care actually live longer than are people that are still struggling upstream against a battle they're going to lose. Next. And so they talk about a lot of important issues, managing pain, organ donation. Next. Hospice, and of course who can make decisions next. And so here it comes. Now the worksheet, and people tighten up. They're afraid that if they put down the wrong answer, we're going to put them down. So next sheet. But it is not true. I want you to remember that what I said before was all the rest of this is about you, but it's not for you. The person that's going to be looking at this will be those names. It isn't going to be me doing that, and sometimes they may not even need to look at that. They know from talking to you. what you wanted, but sometimes a situation with all that nuance I was talking about is such that this is very helpful. At Evergreen, we have a web-based electronic health record. After you've completed this, we have you bring that in. We fax it into the chart, so if you could be in Boston or Germany or wherever, and we can supply this to your family if it would be helpful in making some difficult decisions. Most of the time it's just Dr. Britton or I are seeing you in the ER and or in the ICU talking about things. But I want you to see some of the nuance here. As I think about my medical care, these are the things that are important to me. I want to prolong my life by any means possible. I want to control pain and suffering. I want a quality of life consistent with my values. I don't want to be a burden to my family. I want to save my family money. I have these religious beliefs. A lot of times people will say, you know what, I want to live and I want to be resuscitated if I can have a quality of life. That's great. That's a start. Now you have to tell me what you mean by quality of life. Because what you mean and what another person means isn't necessarily the same thing. Thinking well enough to make everyday decisions, just being comfortable and free of pain, what do you mean? What is being, and none of these are absolute. Again, this is just a guide, not me, is to guide those names you put down there if they're not sure what it is you wanted. And as you go through these, in any of these questions just don't resound with you, I don't know how to answer that, just ignore it. Move on. You don't have to fill it in just because it's there. But as thoughts do come to you about quality of life, just write it in freehand. You can't fill these out wrong. But what you do is share what is meaningful to you. The one lady talking to her daughter said, I want them to know who I was. And when I'm no longer that person, I don't want to be here. And your kids or your loved one, your spouse knows who you were. And so there's a lot of opportunities to feel. If I'm in the final stage of an illness, it can't be cured, maybe it's cancer, but I have another illness that can be cured, and I can't speak for myself, what do you want me to do? And so that could be a bowel obstruction, you need surgery, or it could be pneumonia and you want treatment. And if you don't say, well, I can't answer that yes or no, then write it in. If I'm severely demented, I don't want to treat it, but if I'm in really severe pain and working with some adhesions for bowel obstruction, making me more comfortable, go for it. And if I pass away in the surgery, that's fine. Just write it in. All you're doing is a letter to the people that you put down as making your decisions for you. Understanding that if you're able to make your own decisions and talk to us, we don't go to them, we go to you. Next. And so go ahead and go on. There's lots of room just to write freehand if none of this goes on. They talk about things like donating my organs. How many of you guys have talked with your kids about that? Maybe you have, but good for you. But most people don't. And they, when it comes and is asked, do you mind if we, harvest the eye, or whatever the cornea is, who would know? Go ahead and go to the next one here. They even talk about things that if I have a choice, here's where I want to die, in a hospital, a nursing home, a home. The reason I want to die that way is this. I'd love to have these people with me if possible, my other preferences. I want to have my... You don't have to fill these things in if you don't want to, but I will tell you, the person it's a message to is the people that are going to be making the decisions. And if it's important to you that they be your decisions, then you need to fill it out. And once again, I will say every year as you come in to your doctor, that should be reviewed because things change. What you said before, and if it's too much of a change, we'll just take that one and give you another one and fill it out. Sometimes we'll look at the name, are these names still good? And they say, no, that person passed on, or he moved to Florida, whatever, I need to put somebody else's name there. The next, I think that's just about it. Okay, I talked more than I intended to. Do we have some questions now?
How do we pass it forward? Go ahead and pass your questions to the ends of the rows, and we'll pick them up.
Oh, thanks. If you would like, we're going to do more of these. It won't always be me up here, yeah, but no, we have Evergreen is really growing. as a primary care base, and we hope to have a structure of primary care throughout Douglas County. And we're very much engaged in starting a family medicine residency here to train new young doctors to be able to bring them. In May, it looks like Dr. Pat Clyde and Alicia Morrison, who's a nurse practitioner specializing in diabetes, will be here to talk about diabetes. So we'd love to have you attend if you want to.
Got some questions coming here, so I will take a look here. Okay. All right, so this question is, do I have to ask to keep my mouth moist? Well, certainly when we're taking care of folks in the hospital, regardless of what their desires are for any treatment, our primary goal is to keep them comfortable, is to make sure that folks are just as comfortable as the situation will allow. So if we find their person has a dry mouth, regardless of the circumstance, if they're able to safely swallow, we'll make every effort to make sure that they have liquids that are needed. If they can't swallow, then we'll use a swab, and our nursing staff is very good about making sure that we do everything that we can do to keep folks comfortable. There's a question here about Life Alert. Do we need 2 or just 1? I talk to lots of folks about having a Life Alert or a medical alert or something like that. And here's my recommendation. For the folks that I see who live alone and they don't have someone that expects to hear from them or see from them every day, that's a given. They really need a Life Alert, and they need to wear it. A lot of folks will say, well, I have it, but I leave it by the bed because I know where it is. Well, you're not going to fall by the bed. You're going to fall in the bathroom. You need to wear it. So if there was a concern about having 1 or 2 Life Alerts, I would say that probably, again, 1 is probably sufficient for your home. But if there are 2 people in the home and one of the persons has memory impairment and they really can't make those decisions, it doesn't need to be on the person with memory impairment. It needs to be on the other person. Because that person, frankly, may not remember that they're even wearing the device. So I recommend that the person who has the better memory of the 2 needs to be wearing the Life Alert. Here's a, yes, sir.
Is that sent to from your home to where?
So the way that typically works, and there are lots of different medical alert companies that are available and provide things. Usually what's done is the company will be contacted and they'll actually send the equipment to your home, and they will have instructions in the equipment about how to set that up, about which phone numbers you want to have called. And then you decide who you want to have called from that. The Life Alert, for instance, we helped a friend of ours set up a Life Alert here locally, and when we did that, the first call went to a family member, and then there were 3 other neighbors who had their phone numbers in there, and then the last one in the whole line, after all those others had been called, was 911. Because again, most of us are closer, and we were going to be able to be there. But you can have it so that it will go to a family member that's in the area, or if you're concerned and there's nobody there for you, you can have it go directly to 911. So here's a question here about a person helping to care for a mother who has Alzheimer's disease. How would you describe severely demented? That's really kind of a difficult thing to answer with clarity, because dementia can wax and wane so significantly. Anybody would say that a person with severe dementia is someone who is not able to prepare their meals because they cannot remember how to do that. They're not able to dress themselves because they can't remember how to do that. They're not able to bathe or live independently. Those would be very straightforward descriptions of severe dementia. But there are other people that really have pretty severe memory impairment that don't look quite so bad. They can get some help from their family members to come to the table, and they can still feed themselves. So it's kind of it's very gray between the time you go from moderate dementia to severe dementia. And really, from my standpoint as a physician, it doesn't really make any difference with regard to medical treatment that I offer that person, but rather it makes a difference as to what kind of supports I recommend for that person. I have a person that I'm caring for now who unfortunately does not have any family members in the area and who does indeed have very severe dementia, and presently we're making arrangements for her to get a higher level of care. Now, this is a lady that can still remember how to comb her hair. She may not remember where she puts her comb, but when she has it, she can remember to comb her hair. But she is not in a position to make decisions for herself. She's not in a position to arrange her meals or other things and needs that guidance. So, let's look. Do you have anything else to say?
I talked about nuance, and boy does that apply in dementia, whether it be Alzheimer's or a different type of dementia. It's not a single entity. People don't respond the same. Some people continue to be very pleasant and sweet, and other people, unfortunately, quite the opposite. As long as the person is able to provide some of the most basic self-care and get around, people can oftentimes, and if they don't wander, because a lot of times wandering at night can be very difficult, people can deal with that fairly well. My mother got to the place where she was entirely bedridden and not able, she was kind of curled up and not able to speak and not able to swallow, and that certainly is severe dementia.
So here's one where a person says, my current advance directive was prepared many years ago. Is it important to prepare a new one? Not necessarily. If you pull out your advance directive and it still says the things you want it to say, then you certainly don't need to prepare a new one. On the other hand, I looked at a fellow's advance directive recently, and he had finished that many years ago and had listed as number one the person who was now his late wife. And he said, well, my son's still on there, so it's okay. But again, it's probably worthwhile to say, okay, well, who's going to help my son? So just, it's worth visiting again at some point.
And the other thing I would say about the advance directive, know where it is, have it available, and have it available to your doctor, because it really isn't doing you any good in the drawer back home. In my mind, this is something that should be reviewed, and I think it should be reviewed with your healthcare provider every year. It can take just a second. No, things are much the same. Sometimes people say that, and then we look at, well, they aren't at all the same. And and if it is, great, we just move on, and I put a little note in the chart that we reviewed it and everything's up to date. But it's worth just a few moments to look at it and look at it together and make sure you're still kind of feeling the same way, or maybe you had some events and made you think about things different, and you want to add it.
So here's a couple of questions about the post, and I'm going to answer these kind of in a broad range. So one of the things to know about the post is it is a physician's order. So for it to be active, it does require a physician's signature or a provider's signature. If you happen to have a nurse practitioner or a physician's assistant who is the person that's your primary care provider, then that person can sign the POLST. But the POLST does have to be signed by a medical provider, a licensed medical provider, for it to be active. There is a POLST registry, and so what we do at the office when we help someone to complete a POLST and I sign that, we make a copy of the POLST and then we submit it to the registry so that that is on file there. The intention with that is that medical personnel can find that information through the registry as well. And then here's a question about if you get CPR on the street and end up in the hospital on a ventilator, what does it take to end it after they find your advance directive? And every now and again we will have somebody that will come in and they will have gotten resuscitation and that was not their intention. Once we can gather the assembled family members who can confirm that that was the intention, then we certainly make sure that that person is kept comfortable and we can withdraw life support at that time. Fortunately, that rarely happens. The sad part of CPR on the street is very, very few people survive that to make it to the hospital. Every now and again we'll see that, but it's unusual for that to occur. The final thing that I'm going to mention, then I'm going to turn it back over to Dr. Powell to wrap up. So I'd mentioned, and I did. I grieved the loss of my friend, and there's a question here that asks how would an advance directive or a POLST have helped in that situation. The thing that would have been a helpful thing for him is if I'd had the foresight or other family members had had the foresight to say, you know, he's really not doing well. We want to do everything that we can do to keep him comfortable at home. We don't want to take him to the hospital. And so with regard to the POLST, if we had changed that such that it said comfort measures only, then we would have been able to continue with comfort measures in his home. And oftentimes, and I will tell you, it's oftentimes very difficult to know at the end of life if there's something that's reversible or not. So oftentimes family members and we as medical people will give folks, well we do, if we give folks the benefit of the doubt, and if we think that there's an infection or something that can be reversed and then return to their previous state of health, we certainly aggressively treat that. If this fella had said, you know, I'm just tired, I don't ever want to go back to the hospital, as Tim has indicated, and I've had the same conversation with my husband, if there's a point in my time, in my life, where I can't take care of myself, I'm not able to feed myself or recognize my family, I don't want to be treated for infections. I want to be kept comfortable, and I don't want to go to the hospital because I've enjoyed my family. And that's, again, my own personal feeling, but not everyone feels that way. And the final thing that I would say before I turn back to Tim is that our goal is really to be respectful of folks. We want to offer folks very good care. We want to be very honest about the limits of the care that we can provide. Because even though we can do lots of things, there are many things that are simply not going to be fixed. And we want to make sure that everyone's journey is as comfortable and as well as it can be for as long as is reasonable and possible medically. So, thank you.
I'm going to wrap up things up very quickly. Just a quick comment on the one question about the resuscitation on the street when the person had an advance directive. Folks, there is nothing in the advance directive that will prevent CPR. That just not there. There are sort of those four extreme questions, but obviously if you're walking down the street, none of those apply. And still the only thing that the advance directive is for the nuance, and that would be if your healthcare representative understood that you didn't want to be resuscitated. But if you truly don't want to be resuscitated, you need the post. That's the pink one. And that'll do it. Now, of course, you can still be resuscitated because you didn't carry the post with you. And the worst that could happen is, sorry, here you are. You get a vote again. There's a question about did a law pass that nourishment or water can be withheld in Oregon? You know, there's never actually been a law that you could not do that. There's a nation-grabbing headlines sometimes with Miss Shivel or other things. That always occurs in a circumstance where the family or the people that have a stake are in market disagreement, and they begin legal proceedings. In Oregon, you can do assisted suicide if you find somebody that will cooperate with that. So certainly, if you choose to withhold tube feedings, is utterly legal. And as a matter of fact, I think in a circumstance, for example, as with my mother with severe Alzheimer's disease, it would be incredibly cruel to put a tube down so she could continue to live that existence. The last one here, I'm diabetic. I have three-way bypass. Are there any parts worth saving? God bless you. Live hard. You know, am I totally worthless or what? You know, and God bless you. What a heart. Can I help somebody? And I would say that sometimes there is some things with skin or bone that can be used, and so I would let others decide, and I utterly feel the same way. I've again explained to my wife and my family if they have any spare parts that can be used, I sure want them to be done. You know, folks, I've gone a little longer than I expected, but I sure appreciate being here. It's late on Thursday, and I've enjoyed it. I hope it's been helpful, and we will be having more of these as you see, but thanks for coming out. Dr. Britt and I will be hanging around here. If you do have any other questions you really kind of wanted to push us about, we'll be glad to try to answer those. Thanks again. Good evening.